Welcome to the AOA News Inside Tract podcast. Today's Inside Tract podcast is part of the QIPS Insights series, which is brought to you by the Quality Improvement and Patient Safety Committee. We'll hear from leads of quality improvement and patient safety projects, exploring how they got started, what worked, and key lessons learned.
I am Andrew Harris, Chair of the American Urological Association's Quality Improvement and Patient Safety Committee. I'm here today with Dr. Kevin Koo, an Associate Professor of Urology at the Mayo Clinic in Rochester, and we're so excited to talk with Dr. Koo about his recent quality improvement work that was presented at the American Urological Association meeting on opioid prescribing and patient-reported pain outcomes after percutaneous nephrolithotomy. So, Dr. Koo, tell us a little bit about the project and your work, and kind of, what were you thinking about that said, what, I think this is important and I think we want to go after it at the Mayo Clinic?
Well, thank you, and nice to be with you, Dr. Harris, and to all of our listeners. And thank you for featuring our work. We take a lot of pride in thinking about quality improvement, and we are glad to participate in continuing efforts with the AUA and our partners to do that. Our project, as you mentioned, was focusing on opioid stewardship, and specifically opioid prescribing patterns and opioid consumption patterns in patients who have undergone percutaneous nephrolithotomy, or PCNL. PCNL is a procedure that we perform quite routinely at our center, and it's also a procedure that's typically reserved for complex or advanced kidney stone disease. And as our community, the stone disease community, the urological community, have focused on safe opioid prescribing practices and evidence-based opioid stewardship over the last few years, we noticed that the literature on opioid use and opioid stewardship after PCNL was somewhat lacking. And we noticed that because we were trying to base our prescribing habits on evidence. And when the evidence isn't quite there, it becomes difficult to know exactly how to guide efforts. I think all of us are committed to patient safety. We are also committed to allowing patients to have the best and most optimal postoperative recovery possible. So we needed to know how to prescribe opioids safely, whether all, some, or no patients needed opioids after this procedure, and if so, how we might be able to right size or tailor our opioid prescribing to specific patients, to use opioid use patterns after surgery to guide discharge prescribing. And that's what led us to this quality improvement work.
I appreciate the thoughts and your commentary there. I remember the days when I was in residency, everybody got the same thing, right? And there wasn't really a lot of thought into, how were they going to use them? How were the patients going to take the opioids? What would they do with them when they were gone? Did it actually satisfy their pain needs? Was it going to be beneficial or harmful, right? We just give everybody the same thing. And so I really appreciate the thought process that you've mentioned. So if I can recap, you notice that you really didn't have a standard or a way that you could go look at evidence-based prescribing patterns. And so you just had to figure it out, right? So I really appreciated that part of the abstract. So can you walk us through a little bit more detail about how you went about figuring that out? So you had an issue where you really didn't have a lot of evidence, and so you kind of had to figure out what to do. So can you talk a little bit about how you all went about trying to figure out an evidence-based way to distribute opioid medication?
I think you're exactly right. The first thing we needed to know was where we were starting from, what our baseline would be. And so to do that, we did a retrospective cohort study, which we had previously presented at an AUA meeting, about how our patients were using opioids. And before we had standardized prescribing practices among the several attendings at our hospital who perform PCNL, we didn't really know exactly how folks were prescribing and whether we were using standardized prescribing practices or people were basing decisions to prescribe on various factors, how the surgery went, how the patient did on post-op day 0 and day 1. So our retrospective analysis showed us that the vast majority of patients seemed to do well with little or no opioid use. Now, at our center, many of our PCNL patients stay for a 23-hour observation. and go home the morning of post-op day 1. So when we examined the opioid requirements after leaving the operating room before discharge, we noticed that many patients didn't use any. And it seemed that prescribing opioids for patients who didn't need any opioid medication and whose pain was adequately controlled with simply non-opioid medications like acetaminophen, ibuprofen, and then medications to control stent-related symptoms like tamsulosin, anticholinergics, that those patients shouldn't need additional opioids after discharge. And some patients might have used a few tablets of opioids in addition to their multimodal regimen. And so perhaps those patients might need a few. But we've learned from opioid prescribing work in urology and in other surgical specialties that this idea that everyone needs the same amount or that we should prescribe as a just-in-case prescription is really a concept we should move away from. And so this concept of being able to use patient use patterns immediately after surgery to then determine what patients might need after they leave the hospital really became very attractive to us. So based on our retrospective analysis, we developed an opioid prescribing algorithm for use at the time of discharge. If patients used no opioids in the 24 hours before discharge, then they should not need any prescribing of opioids at the time of discharge. If they used less than or equal to 25 morphine milligram equivalents, which is approximately 3 to 4 tablets of oxycodone 5 milligrams, then they could receive up to 5 tablets of oxycodone 5 milligrams at discharge. And if they needed more than those 25 milligram equivalents, then they could receive up to 10 oxycodone 5 milligram tablets. And of course, all of this was surrounded by a non-opioid analgesia regimen, the ones that I just mentioned. And so that's the algorithm that we put into place. And then it became time for us to test it and see how it might work in the real world. And that's where this study picks up.
Yeah, so I particularly appreciate your use of quality improvement methodology in this work and having a very good understanding of current state. I think in so many improvement initiatives we don't take a lot of time to understand where we're coming from. And we just think we know what the problem is and we try to fix it. Here, you knew exactly what to do. An exceedingly individualized approach to opioid medication distribution based on usage in the hospital. And so I really appreciate that. And I was smiling while you were talking because it just makes so much sense. And so you, again, commenting on how we kind of used to do some things like this is just genius. And it's so patient-centric. It's so, quality-centric and safety-centric for the patient. It is just absolutely phenomenal. And I applaud you all for thinking of it and then wonder why we did it the way we did it for so long. But I guess when people have great ideas, that's kind of how you know it was a good idea. So very appreciate your understanding of current state and using that part of quality improvement methodology. So now I'm anxious to hear how you knew whether it worked or not. So how did you know, right? How did you know the patients were okay when they got home? So if you tell us a little bit about that.
Exactly. So now it's time for us to actually put this algorithm into place. So we decided to study this using a prospective cohort type design, but with quality improvement features and a quality improvement framework embedded within it. And so we enrolled patients who were undergoing standard PCNL, and we measured what their opioid use patterns were in the hospital, because that is the way that we stratify patients into which tier of opioid prescribing they might fall into to help us guide how much they might need. Now, embedded in our prescribing algorithm is this idea that it's not a fixed amount. It's always a range. So even if patients might qualify or be in the range that they could get up to 5 tablets of oxycodone 5 milligrams, if patients do not want any, which we are increasingly seeing patients say, I decline opioids. I don't want that in my house. I'm not interested in using it. Patients are savvy and they're becoming aware that oxycodone and other opioids do have side effects, including long-term use and misuse. And so there's always that idea that we tailor the opioid prescribing to what the patient might need, but also taking into account the patient's goals and preferences for prescribing. We used multimodal analgesics throughout the hospital stay and encouraged it and emphasized it at the time of discharge. And then we put our prescribing algorithm into place. And I think we wanted to develop this algorithm that every surgeon, every urologist who might perform this procedure has access to this information, right? We know what our patients are taking or using or declining when they're in the hospital. And so we can track that and see how patients do. But the real evidence that we wanted to collect here was how patients did afterward, right? How do we know that this worked? How do we know that we wouldn't receive a flood of phone calls or ED visits with patients whose pain was not being well controlled or who were suffering at home? And so it wasn't simply about tracking patient outcomes and patient readmissions for pain control or how patients did, but we wanted specifically to look at patient-reported pain outcomes. And so we called patients and we used a combination of text messaging and direct phone calls at days 3, 7, 14, and 28 after discharge. And we wanted to know not only how patients would rate their pain and how well their pain was being controlled, but also what medications we were using. Because it's one thing to recommend that patients take this multimodal regimen and then reserve opioids if they were prescribed any, only for pain above and beyond that. But it's a different thing altogether to see if patients are actually using it in practice. And so we checked at these multiple time points to try to get a sense of what the natural history of pain experience is after this procedure. And then at 28 days, 4 weeks after discharge, we wanted patients to look back and let us know what they thought their most bothersome symptom was. We checked with them at each time point to see what is it that's really bothering you right now. Is it bladder spasms? Is it flank pain when you void? Is it incisional pain? Is it something else? And that helps us understand also where this algorithm might be working or not working. And so after we did this and we implemented our cohort study, we enrolled 75 patients and asked them at each of these time points how they were doing, what their most bothersome symptoms were, what their medication use patterns were, including opioids, if they used any, and whether or not they felt like their pain was adequately controlled. And at the end of the study, at the 28-day mark, we asked them if they felt like their pain had been better, worse, or about the same as they expected, and whether, if they were prescribed opioids, whether they had any left. And what we found is that overall, the majority of patients reported that their relatively mild pain that they experienced after they left the hospital was resolved within 1 week. And median pain scores were low overall and decreased to minimal or none by day 7. At day 3, the first time point we measured, the median pain score was 3 with an interquartile range of 1 to 4. So all in the mild to perhaps low moderate range. By 1 week, by day 7, the median pain score was 1. And by day 14, it was 0. And the interquartile range was 0 to 2. So I think it's safe to say that the majority of patients have relatively mild or low moderate pain immediately after discharge. And by 1 week, the majority of patients really are doing very well and their pain is minimal, if any, and they're not needing much of anything in terms of analgesia, medications for analgesia anymore. And importantly, the most bothersome symptom that patients reflected on during recovery was bladder spasm, 31%, was flank pain, 28%, and for only 15% of patients was it incisional pain, the type of pain that opioids might be most effective at treating. So as we suspected, what our patients really had trouble with or thought was the most bothersome were the flank pain and bladder spasms and stent-related symptoms that we know really aren't covered well by opioids. And we know that from a robust literature of opioid use and stewardship after ureteroscopy. So we borrowed a little bit from what we already knew from that literature to help inform these results. And using this algorithm, 32% of our patients, so about a third, were prescribed some amount of opioids at discharge, some amount. And among this group, 83% reported taking at least 1 dose. That's consistent with other surgical literature showing that if you give a mouse a cookie, they're likely to take a dose of opioids, as it were. And so we have to be careful about our stewardship because if we prescribe this medication, patients see it as a prescribed pain medication and they're likely to use it, regardless of whether they use other non-opioid medications in addition to it. And importantly, there were no significant differences in pain scores among the groups, whether opioids were prescribed or not. And no patients required a new or refill opioid prescription after discharge, showing that the patients who were not prescribed any opioids, the 2/3 of our patients, never needed an opioid prescription by calling into the clinic, going to the ED. And the patients who did receive some opioids, according to our tiered prescribing algorithm, never needed another one. So what they received was adequate to cover their pain. So I think our takeaway overall here is that we were able to discharge 2/3 of our patients who needed either no opioids or minimal amount of opioids in the hospital without opioids, and they did fine. And the patients who might have needed some opioids in the hospital, they might have received a small prescription, right-sized to their use for use after discharge, and they did well as well.
Well, Dr. Chu, we're coming up on the end of our time together today. Just want to thank you for such a wonderful work on an issue we all know to be a widespread problem, not just in urology, but across our nation regarding opioids. And just really appreciate you approaching this and giving us some information how we can better help our patients, and also applaud you for using just wonderful quality improvement methodology by really understanding the current state well, designing a focused intervention based on the information that you gleaned from your study of the topic, and then studying your intervention to see what you can learn and if it was working. And it sounds like you have a couple ideas and some data points that may help you design a second or third PDSA cycle in the future. So we'll be excited to see those. To our audience, thank you for listening to the podcast, and be on the lookout for new episodes from our QIPS Insight podcast series.
This has been QIPS Insights, an AUA News Inside Tract podcast brought to you by the Quality Improvement and Patient Safety Committee. For more information about AUA's quality improvement and patient safety efforts, visit auanet.org/quality.